everyone, welcome to Try Right. This is Pack 365. I myself Srija. So today in this session you are going to learn about the CPT coding surgery guidelines for musculoskeletal system. So what are the procedures involved? So how the coding is done for the related procedures. So coming to the first procedure, arthroscopy. So arthroscopy, the CPT code ranges are for 29,880 to 29,881. So what is arthroscopy? So it's a minimally invasive joint surgery. So surgery inserts an arthroscope, nothing but a camera, to the small incisions. So it is used to look inside the joint and also to treat the problems. So what are the common joints for arthroscopy? Knee, shoulder, ankle and wrist. So arthroscopy is both diagnostic and surgical. So if a diagnostic arthroscopy is done first and then a surgical arthroscopy is performed, so the diagnostic arthroscopy is included. It is not coded separately. So the CPT code range 29,880 to 29,881. It's a knee example. So for the example is 29,880 code for arthroscopy, knee surgical with meniscectomy and which is a medial and lateral approach, whereas 29,881 code for arthroscopy, knee surgical with meniscectomy which is a medial or lateral approach. So these are the surgical arthroscopy codes. And what is the arthroscopy and an open procedure? So same site, arthroscopy is included in an open procedure. So do not code separately. So example is if an arthroscopy plus open meniscus repair is done on the same knee. So you have to code only open approach. So when it's a different site, you have to code together. So arthroscopy and open procedure can be coded together when it is a different site. So you have to use appropriate modifier, which is usually 59. If it's an arthroscopy and arthrotomy approaches. So arthrotomy, it's an open surgical incision into a joint. So if both are done, if both arthrotomy and arthroscopy is done, you have to append modify 51 because it's a multiple procedure. So next procedure is application of cast and strapping. So CPT code range is 29,000 to 29,799. So what are these codes used for? So they are used for the initial or subsequent treatment of the fractures, ligament sprains or tears and overuse of the injuries. So this code describe how the application and not the fracture repair itself. So how the application done. So what is in cast application? So why cast is applied to immobilize the injured part. So the materials used in the cast are examples plaster, fiberglass and thermoplastics. So each cast is defined by the body part, by the position and by the type of the cast. So the examples of the cast are short arm cast, long leg cast and thumb spica cast. So what is strapping? So strapping it's a tapping or a wrapping a body part. So the purpose of strapping is support, compression and limit the movement, not full immobilization. So these are commonly used for the sprains, mild injuries, sports and medicine cases. So what is a very important coding rule here? Cast and strapping codes, they are not reported when they are a part of fracture care package and the same physician provides a global fracture care. So they can be reported when provider is only applying the cast and another physician is managing the fracture care. So the purpose of the splint, cast and strapping is to provide stability, immobilization and support. So these are commonly for sprains, strains, dislocations and also fractures which are temporary or definitive. And what are the splints used? Materials like wood, cloth, metal and plastic. So these are usually temporary. They allow the swelling. So they are common in emergency settings. So example like volar splint for wrist injury. And what is an important bunding rule? So removal of cast, strapping or splint is included in the application codes 29,000 to 29,799 code ranges. So do not code them, do not code the removal separately. And when surgery is performed, the following are bundled with the surgery. So what are those? Surgery, application, cast application and cast removal. So all these are included in the surgical CPT code. And next is musculoskeletal surgery, the fracture and or dislocation, the main treatment categories. So when coding fractures or dislocations, look for how the bone was treated, whether it's a closed treatment, percutaneous skeletal fixation, or ORIF. ORIF means open reduction internal fixation. So the first process is closed treatment. So what is a closed treatment? There will be a no surgical incision and bone alignment may or may not be corrected manually within the closed treatment. So this is often followed by the casting or splinting. And the type 1 closed treatment is done without manipulation. So bone is already aligned here. Physician does not reduce the fracture and immobilization only. So documentation clues is a stable fracture, no reduction required, and it is treated with the cast or splint only. And the type 2 is close treatment with manipulation. So physician moves the bone back into position. Reduction is performed without incision. And the documentation clues whether the reduction is performed or the fracture is reduced or it is manipulated into the alignment. And next is percutaneous skeletal fixation. So percutaneous skeletal fixation, it's a small skin punctures where pins, wires or screws are placed. So it's no open incision in the percutaneous skeletal fixation. And part 5 is ORIF, open reduction internal fixation. It's an open incision, bone is directly visualized and hardware is placed. So what hardware? Maybe plates, screws and rods. So how to find the right code in the CPT search for musculoskeletal surgery guidelines? So always look for the bone involved, look for the location, whether it's a shaft, head, distal or proximal, and the type of the treatment, whether it's closed without manipulation, closed with manipulation, whether it's a percutaneous fixation or ORIF, and also check for laterality, whether it's right or left. So how to search the fracture or dislocation codes? 20,000 series. So most fracture and dislocation treatment codes are founded in the CPT 20,000 series. So mainly from 23,000 to 27,000 range. So step by step search method. So first step is search the index and look for the body part. Then choose for fracture and dislocation or fracture and or dislocation. So example index part is femur. In femur you have to find fracture. In fracture it's a shaft. And step 2 is identify the bone. For example, whether it's a femur bone, radius bone, ulnar bone, tibia or a humerus. And step 3 is to identify the type of the treatment. So this is the most important step for CPT. What is the type of the treatment? So whether it's a closed treatment without manipulation, whether it's a closed treatment with manipulation or percutaneous skeletal fixation or open reduction internal fixation. So the same fracture can have different CPT codes depending upon the treatment. And here is an example. Closed treatment of femoral shaft structure, which is a CPT code range 27,500. So why 27,500 is assigned? Because the bone involved here is femur, location is shaft and treatment is done closed. So there is no insertion and there is no placement of the internal hardware. So the code represents the closed treatment of the femoral shaft fracture. And second example, open reduction and internal fixation, ORIF of distal radial fracture. So what happens in ORIF? Physician makes an incision, fracture is visually exposed, bone is reduced and hardware may be placed. For example of the hardwares are plates, screws, nails, pods and intermedullary rods. So this automatically makes it ORIF but not the closed treatment. And the important ICD versus CPT rule, which is a high yield. If the physician does not mention open or closed fracture type, so always code ICD diagnosis as the closed fracture. So even if an open surgical procedure was done or if was performed, so this rule applies to ICD coding but not the CPT. So procedure can be open but diagnosis can still be closed. So this is the main ICD guideline. And next procedures are regarding splint, cast or strapping rule. So if the same physician performs fracture care and applies a cast, splint or strapping, so do not code a cast or splint separately. So because fracture treatment codes include application, follow-up care and removal. So when can this cast or strapping be coded? When a different provider applies the cast when no fracture care is provided. So fracture treatment CPT codes already include application, follow-up care and removal of cast or splint. So when can you code splint or cast strapping? When two different physicians are involved. For example, physician A performs the fracture care, physician B applies the splint, cast or strapping. So code this splint, cast, strapping for physician B only. Because same doctor, it's a bundle service. If it's a different doctor, it is billable. And next part is fracture treatment. So what are the examples here? Open treatment of the distal radial fracture. CPT code 25607. Here the incision is made, the fracture is exposed and reduction is performed. And hardware is also usually placed. Nothing but it's a procedure under ORIF. So 25607 code is assigned. And close treatment of tibial shaft fracture. So there is no incision as it is a closed treatment and the bone aligned without opening. Immobilization follows because it's a closed treatment. So 27750 code is assigned. And third example is humeral closed fracture treatment with manipulation. So there is no incision and physician manually reduces the fracture. So CPT code 24505 is assigned. And open treatment of metacarpal bone. So in this case, the incision is made as it is an open treatment and bone is reduced directly and there is a possible fixation. So you have to assign 26615 code. And next is arthrocentesis. So what is arthrocentesis? It's a physician punctures a joint to aspirate a fluid or inject a medication, for example like a steroids. So what are the common reasons of arthrocentesis? Joint pain, swelling, infection and arthritis. So in this case, in the case of arthrocentesis, joint size matters for coding. For example, fingers, toes, wrist and elbow. So the codes 20600 without ultrasound guidance, 20604 with ultrasound guidance. So this comes under the small joint. So small joint always includes the examples of fingers, toes, wrist and elbow. So if ultrasound is used, do not code the guidance separately. And next is intermediate joint within the arthrocentesis. So examples like shoulder, knee, ankle and wrist. So the code is 20605. It is assigned for without ultrasound guidance. So there is also 20606 for ultrasound guidance. And the guidance coding rule is if the ultrasound guidance is given included in with the ultrasound guidance code. So other guidance is fluoroscopic guidance and CT, computed tomography guidance. This may be coded separately if documented because they are not involved in the code. Only ultrasound guidance is included in the arthrocentesis code descriptions. And large joint codes. So 20610 without ultrasound guidance. So needle placed without real-time ultrasound. So physician may use other imaging guidance but ultrasound is not used here. So other guidance can be coded separately. And 20611 it's for ultrasound guidance. In this, the real-time ultrasound is used and needle placement is visualized. And ultrasound guidance is included. So do not code ultrasound separately with the 20611 code. And other imaging guidance codes are what are the additional codes? So if arthrocentesis is done using non-ultrasound guidance and separate guidance codes, so give this add-on guidance codes. So these are the add-on guidance codes. Fluoroscopy, the CPT code is 77002 and for CT guidance 70012 and for MRI guidance 70021. So arthrocentesis of the shoulder under CT guidance. Here an example. So arthrocentesis of shoulder, you have to assign the code 20610 for large joint and no ultrasound guidance is performed. There is only CT guidance performed, hence assign the code 77012 for CT guidance. And second example is arthrocentesis of shoulder using ultrasound guidance. So as ultrasound is included in 20611 code, you have to assign the code 20611 only. And next procedure is arthrography. So what is arthrography? So what is arthrography? It's an injection of contrast material into a joint. And this arthrography, it is followed by imaging such as X-ray, CT and MRI. So what is the coding rule for arthrography? So usually two CPT codes are used when one physician performs it. So it involves injection procedure code and also the supervision and interpretation codes. So because arthrography has a procedural part injecting contrast and a radiology part interpreting the images. So when two different doctors are involved, Dr. A performs injection, Dr. B performs supervision and interpretation. So each doctor bills only the code for the service they perform. So what are the two components of the orthography? Injection code and supervision and interpretation code. So what is a very important rule here? So never code 77002 for fluoroscopic guidance with orthography and SII codes. So even if fluoroscopy is documented and fluoroscopy is clearly used. Why? Because fluoroscopy is already included in the orthography and supervision and interpretation codes. So what are the common orthography codes? Shoulder orthography, 23,350 code for injection into the shoulder joint and 73,040 for supervision and interpretation. So code together when same physician performs both. About knee orthography, 27,369 for injection and 73,580 for SII. Ankle orthography code, 27,648 for injection and 73,615 for supervision and interpretation. So arthroscopy. So what is arthroscopy? Endoscopic procedure inside a joint. So this can be diagnosed or surgical. So diagnostic plays surgical arthroscopy role. Do not code both diagnostic and surgical arthroscopy. So code only the surgical arthroscopy. Reason? Because diagnostic portion is bundled into the surgical arthroscopy. What are the multiple procedures during arthroscopy? Surgeon often perform multiple procedures in the one joint and he code all the procedures. But some procedures are bundled. Bundling depends on CPT rules and NCCI edits. Same joint versus different joint. So in same joint, you have to apply the bundling rules. Some procedures may not be separately payable, whereas in different joints, code each joint separately. Bundling rules do not apply across the joints. So same joint, bundle rules, different joint, separate codes. So biopsy, what is a biopsy? A biopsy is a procedure where the physician removes a small piece of a tissue and sends it to pathology. So this is used to confirm the diagnosis like for example cancer, infection, muscle disease, bone lesion, etc. And what is a biopsy CPT code range? So most muscle and bone biopsy codes start from 20,200 series. So always check the bone part, the body part, the technique, whether it's a needle versus open, and imaging guidance used or not. So what are the types of biopsies? Muscle biopsy and bone biopsy. So in muscle biopsy, we have two methods, needle muscle biopsy and open muscle biopsy. In needle biopsy, it's a small incision. A needle is used to obtain the tissue and it's less invasive compared to open muscle biopsy. So for example, the code is 20,206 for needle biopsy of the muscle. And in open muscle biopsy, there is a surgical incision, there is a direct visualization and more tissue is obtained. For example, open biopsy codes have higher complexity than the needle biopsy. Coming to bone biopsy, in bone again we have two methods, needle bone biopsy, open bone biopsy. So in needle bone biopsy, we have a percutaneous approach. It often needs an imaging guidance. So percutaneous is the approach is done through a skin. And open bone biopsy, there will be a surgical exposure of the bone. It is more invasive process. And imaging guidance. So this is very important rule. If biopsy is done via needle, you must check whether imaging guidance was used or not. So these guidance codes are add-on codes. So they are reported separately if documented whether the guidance is used maybe an ultrasound, maybe a fluoroscopy, CT guidance or MRI guidance. So to build the imaging guidance, guidance must be clearly documented and it must be the image saved and report documented, especially for the ultrasound. So for example, the scenario is right arm muscle biopsy using ultrasound guidance via needle. So 20,206 code for needle muscle biopsy and 76942 is for ultrasound guidance. So the final codes for this example is 20,206 and 76942. And next is trigger point injection procedure. So the CPT code ranges are 20,552 and 20,553. So what is a trigger point? A trigger point is a tight, painful knot in a muscle that causes pain when pressed. So what is a trigger point injection? Injection of a medication, local anesthetic plus steroid into a trigger point to relieve the muscle pain. So 20,552, it includes injection into one or two muscles, whereas 20,553, it includes injection into three or more muscles. So coding depends upon the number of muscles treated, but not the number of injections. So here is an example. Physician gave 2 injections in the levator muscle, 2 injections on the rhomboid major muscle. So muscles treated here are 2 muscles, but injections are 4. So you have to assign the correct code 20,552 as it involves a number of muscles. So next is the removal of hardware or implants. So what does this mean? Removal of the screws, plates, rods, wires or implants that were previously placed in the body. So 20,670 code, it describes removal of the hardware superficial near the skin surface. Whereas 20,680, it describes removal of the hardware deep, which is buried deep in the tissue or bone. So CPT code depends upon the number of incision but not the number of hardware removed. So for example, there is one incision and multiple screws removed through that single incision. So you have to report only one CPT code. So one incision is one code. So if separate incisions are made at different sites, CPT may allow multiple codes. You have to check the bundling rules. So imaging guidance usually included unless stated otherwise. And procedure excision, skin lesion removal. So what is excision? It's a complete removal of a lesion to the dermis, that is a full thickness of skin including the margins. So excision is the full thickness removing through the dermis including margins, and always it includes the simple closure. Margins are included in this. Simple closure is included but not intermediate or complex closure is not included. If they are documented, you have to code them separately. So what are the coding rules for excision? Code based upon the benign versus malignant lesion, the location of the lesion and total excised diameter including the lesion size plus margins. So each lesion is reported separately. So what is the steps? What is the step-by-step approach for excision coding? So step 1, you have to first identify the type of lesion, whether it's a benign or malignant. So this is the first and most important step because CPT code ranges are different. So when to consider the lesion? When it is a malignant, so if the medical record mentions carcinoma, sarcoma, cancer or malignancy or a positive margins, so pathology confirms cancer. So then code as a malignant lesion. So when to consider the lesion is benign? When there are no cancer terms mentioned. Lipoma, cyst, nevus, skin tag, seborrheic keratosis, etc. So if nothing clearly says cancer, you have to assume it as a benign. And step 2, identify the site of the location. So location decides which CPT code range to use. So the common locations are trunk, chest, back, abdomen, arms, legs, face, scalp, and neck, and also hands or feet. So step 3, identify the size of the lesion. So physician may document 2 cm, 4 cm, 1.2 cm or 4 into 6 into 8 cm. So for excision, we care about the greatest dimension unless square centimeter is required. And what is the step 4? So this step avoids common exam mistakes. So if CPT code is based upon centimeters, so take the largest single diameter. For example, if the lesion size is 4 into 6 into 8 centimeter, so take the largest number only and choose the 8 centimeter here. So multiply the two largest dimensions. For example, lesion size 468. So you have to multiply 6 into 8 per square centimeter to convert the centimeter into square centimeter. So 6 into 8, it's 48 square centimeter. So never add the sizes together in the excision coding. So even if it's a multiple excision, same site, same CPT code. So each excision is coded separately. For example, 2 centimeter lesion excised and another 3 centimeter lesion excised. Same body area. So do not code as 5 centimeter here. You have to code 2 separate excision codes for 2 separate lesions. And bundling rule with excision, which is a very important. So simple and intermediate repair. So simple includes one layer closure and intermediate it includes layered closure, which involves dermis plus skin. So what is a simple and intermediate repair? So always bundle with excision. So these repairs are always bundled with excision. So do not code separately even if clearly documented. If physician performs excision, code only excision. Whereas in complex repair, it is not bundled under excision. So this can be coded separately with the excision. If physician performs excision, you have to code both. Excision and complex repair, you have to code both. So part 2, how to calculate the length of the excision. So what length do we code? Total excised diameter, which includes the margins. So the formula is excision length is equal to lesion size or lesion length plus 2 into margin. So there is an example here. Lesion length is 3 centimeter and margin length is 0.5 centimeter on each side. So total lesion length is, you have to calculate 3 plus 2 into 0.5 and the total lesion length is 4 centimeter. And margins are added only if physician documents them. So if physician documents total excised size, you have to use that directly. Do not guess the margins. Our next topic is spine orthodesis, nothing but fusion. What is spine orthodesis? It's a surgical fusion of 2 or more vertebrae to stop the painful movement. What is the steps? So step 1 is to identify the approach. So approach means how the surgeon reaches the spine, whether an anterior approach from the front, posterior from the back, or lateral from the side. So different approaches have different CPT codes. And step 2, identify the number of segments. So each spinal segment must be coded separately. One segment is equal to one code. So 2 segments is equal to base code plus add-on code. For example, there is a fusion at L4 to L5 segment. So it's a one segment. Fusion at L4 to L5 and L5 to S1, 2 segments. So you have to add one base code plus one add-on code. And here is a code range 22,532 to 22,634. So this is used based upon the approach and number of segments. Number of segments or interspaces. So what is the rule? Number of segments is equal to number of vertebral bones minus 1. So why? Because fusion happens between bones, not on the bone itself. So examples is fusion between C4 to C5. The bones are 2. Segments 2 minus 1 is equal to 1 segment. So fusion from L3 to L5. The bones are 3. L3, L4 and L5. Segments are 3. So 3 minus 1, 2 segments. And what are the spine regions mentioned? Cervical, the neck region, and thoracic, the upper and mid back region. So lumbar often implied in the questions. So region matters because CPT codes differ by the spine area. And step 3 is check for the bone graft usage. Was a graft used? If yes, coded separately. So what are the types of graft? Autograft, allograft, morselized graft, and structural graft. So CPT code ranges for grafts is 20,930 to 20,938. So step 4, check for instrumentation. What is instrumentation? Usage of rods, screws, plates, and cages. So what are the type of instrumentation? Segmental, which is attached to multiple vertebrae, and non-segmental attached to one level only. And CPT code ranges are 22,840 to 22,851. So what is an important rule here? If physician does not specify whether instrumentation is segmental or non-segmental, so you have to assume it as a segmental approach. And approach rule. Instrumentation approaches must match the orthodesis approach. Anterior approach, anterior instrumentation. Posterior approach, posterior instrumentation. So step 5 is imaging guidance. So if imaging is used, for example, fluoroscopy and intraoperating imaging, so you have to code the imaging separately if it is documented. So never assume imaging, must be documented. And step 6 is orthodesis for spinal deformity. So what is spinal deformity? Kyphosis, lordosis, and scoliosis. So what is the coding rule? Only the orthodontist CPT code changes. Graft and instrumentation rules remain the same. And CPT code ranges for deformity orthodosis is 22,800 to 22,819. So what is an example? If the fusion is done for scoliosis, you have to use spinal deformity orthodosis code. So still code for bone graft if it is used and instrumentation if it is used. So here's an example one, step-by-step breakdown. So the operative statement is posterior orthodosis of L5 to S1 for degenerative disc disease utilizing morselized autogenous iliac bone graft harvested through a separate facial incision. So step one is to identify the approach, posterior approach. Second is identify the number of segments. 2 vertebrae, it's 1 segment, 2 minus 1. And step 3, select orthodosis CPT code. So the posterior lumbar fusion single segment is the code is 22,612. And step 4, check the bone graft. It's a morselized, whether it's a morselized, autogenous or harvested from the iliac crest. So here the bone graft is harvested from the iliac crest. So separate facial incision allowed to code the graft and correct graft code is 20,937. And there is no instrumentation, do not code the instrumentation. So next is Achilles tendon repair. So what is Achilles tendon repair? A surgical repair of a ruptured Achilles tendon back of the ankle. Primary procedure versus secondary procedure. So in primary procedure, which is a primary repair, first time repair, there is no previous surgery, no old surgical scar. Whereas in secondary procedure, this is the re-repair and prior surgery already done and scar tissue is present. So CPT code 27,650, it's a primary repair ruptured Achilles tendon repair, which is an open or percutaneous approach. Whereas 27,652, it's a primary repair Achilles tendon with graft. So graft harvesting is included in this code. So in 27,654, this is with or without graft. So in secondary repair, graft is not coded separately. And next code is 27,656. So what does this mean? Repair of a facial defect of a leg. So fascia is the connective tissue layer covering the muscles. This is commonly repaired after a trauma and hernia-like defects or surgery. So the key point is this is not a tendon repair, not a skin repair, and it's a deep soft tissue repair. And coming to joint replacement, total knee replacement codes are CPT code 27447. So this replaces the entire knee joint and we have total hip placement or arthroplasty. So this replaces the entire hip joint. So the code range is 27130. So these are the major procedures and usually include the approach, implant placement and closure. So separate procedures, what does a separate procedure mean? They are not reported if another more extensive procedure is done on the same organ or area. So some CPT codes are labeled as a separate procedure. So when can you report a separate procedure? Only when no other procedure is performed on the organ or site. And next, amputation, it's a surgical removal of a limb or a part of a limb. It is normally done below the joint or above the joint. So coding depends upon the level of the amputation, the side, whether it's a right side or left side, and the reason for the amputation, whether it's a trauma, disease, and etc. So these are the guidelines regarding the joint replacement. And this is for today. These are the guidelines for musculoskeletal system surgery CPT coding guidelines. So I hope this session has helped you. In the next session, you will be learning the CPT coding guidelines for respiratory system surgery. Thank you.